gentlemen. Good morning. I found it appropriate in times of increased hostility and aggression, even wars and threats all over the world, to talk today about peace, as the title suggests, peace for everyone. But Jan, again, we blame Jan, didn't agree and specifically asked me to talk about delta P, which is pressure gradients or differences in pressure. And more specifically, or preferentially, about transmural pressure and in the lung, applied in the lung. That was already mentioned by Carlos. We call it transpulmonary pressure. And Jan is right. When we measure blood pressure, actually that does not give us much information, or a pressure, wherever, lung pressure, blood pressure. I'm a I used to be a cardiac anesthetist, so cardiovascular physiology is my comfort area. Here I am a bit out of it. But in the circulation, if you measure blood pressure at one point, that's intraluminal pressure, we always have to relate it to another pressure, to interpret it as a pressure difference, for example, against the atmospheric pressure. If we measure blood pressure, that's always related to the atmospheric pressure. Whether we are high above the sea level, or whether we are diving under the sea level, our blood pressure, the one that we measure, will always be the same, because the principle relates it to the surrounding pressure in the atmosphere. Although the absolute pressure will go down. Absolute pressure will go down in our circulation if we climb a mountain, and it will go up if we dive, but our heads will not explode under 3 atmosphere, because it's the entire body that is under that same pressure. So always makes sense if you relate it to a reference pressure. And the formula we're all familiar with in anesthesia, as it comes to physics, pressure is flow times resistance, right? It's just another example that it's not pressure that needs to be there, it's pressure difference that will drive blood, or will move blood or air through the bronchial system. The pressure difference relates to flow and resistance, as you all know. And applied to the systemic circulation, that means mean arterial pressure minus central venous pressure, not just mean arterial pressure. Although in that example, it's less important because it's a low value that we can actually, or basically, neglect. That's not the case if you do calculations in the pulmonary circulation, because we have mean pulmonary artery pressure being much lower in absolute values, and have to subtract wedge pressure. Small mistakes in wedge pressure measurement can lead to very wrong conclusions when we calculate pulmonary vascular resistance and its reaction to drugs, for example. There it becomes relevant that we do measure the 2 pressures. And what I use now as an example is driving pressure. Driving pressure that acts upon blood or air along the axis of that tube. So here is the illustration. If we measure blood pressure, I think I have a pointer here. What's the button? Yeah. If we have 2 pressures in a vessel, it is the difference between those pressures along the axis of that vessel that actually relates to flow and resistance according to this formula. But there's a second pressure difference that we need to take into account, hydrostatic pressure, because we're talking fluid dynamics, so the height of that column will also change the values, the individual values, if they are not at the same level, measured at the same level, like in upright position, where brain pressures in brain circulation are actually much lower than the ones we measure at heart level. That's common knowledge. The third pressure difference of relevance here is transmural pressure, and that actually runs along or perpendicular to the long axis of a vessel, and refers to a pressure gradient across the wall. And so pressure difference across a radial axis and across a wall. That's transmural pressure as opposed to driving pressure. And hydrostatic pressure, all to be taken into account because it's only pressure differences that drives motion, deformation. That's the force. The difference will be the force that is relevant in physiology. So, and that applies to collapsible tubes, of course, because pressure differences do not have much effect on the vessel wall. If that vessel wall is very rigid, like in the trachea, for example, the cartilage prevents it from being dilated or compressed. Also for cavities, like the cardiac chambers, the net result, therefore, for two opposing or opposite forces, because pressure is force over area. If we discuss the same area, then it's the same physiological meaning, simultaneously on both sides of a wall, in Latin murs, hence transmural pressure difference. It causes wall motion and deformation. It changes when it comes to vessels, the diameter, and it affects volume when it comes to chambers. That's basic physiology, almost high school physiology. And then I thought I was clever, and I was going to ask AI to illustrate the concept, as Emile Boulpap in his fantastic book on physiology suggested, well, to illustrate it to students, the door, with one guy pushing on one side, the other on the other side, if they push equally hard, the door will not open or will not close at all. So I said, maybe generate a picture of two men pushing on the opposite sides of the door. And that's what I got. And I tried different phrases, and I said inside the room versus outside the room. I got very complex pictures, but certainly a white and a black man pushing on each side of the door. I'm not sure what exactly they are trying to reach with this. So, artificial indeed, intelligent can actually confirm that. The clinical relevance of transmural pressure, the pressure inside versus the pressure outside a wall in cardiovascular physiology, many examples. If you turn on PEEP, that means outside of the wall. You increase the pressure. That partially transmits also to inside of the wall, but the increase in pressure is predominantly external, so the transmural pressure decreases, and that means that cardiac loading decreases. Cardiac chambers, veins are compressed. Pericardial tamponade, of course, there the external pressure due to blood collection increases, and then transmural pressure, or the difference, decreases. Also inhibiting filling. And another less familiar example, if you drain patients with hydrocephaly and an aneurysm, if you drain the intracranial ventricles, that can cause rebleeding. It's a high risk for rebleeding of an aneurysm, because what you do now is you take away the pressure externally, and although blood pressure doesn't change, it changes the transmural gradient and blows off the aneurysm. Okay, enough of cardiovascular, I had my thing now. Let's move to pulmonary physiology, because there the transmural pressures drive ventilation. This is a basic slide again, illustrating what you all know. The lungs tend to recoil to smaller volumes, while the chest at rest tends to expand. And those opposing forces pull away from each other, hence create a negative pressure in the chest and in the pleura. That negative pressure is here illustrated for an upright position, is that negative pressure surrounding the lungs. And here are absolute values, but this time, in cardiovascular it's millimeters of mercury, and in respiratory physiology we use centimeters of water. But here are the absolute pressures in millimeters of mercury, just to make it more confusing. And here are the values relative to the atmosphere of the intrapleural space. So you see they are negative due to these opposing forces, and there is a hydrostatic gradient. The lung hangs on the wall but pulls more on top of it, so pressure difference will be higher than on the bottom. Also for patients in supine position, that gradient exists, is a bit smaller, but it is there, so it needs to be taken into account if we are going to calculate transmural pressures. And transmural pressure for the lung is not now, as was already indicated, it's not the difference between the outside world, the atmosphere, and the inside of the lung. No, it's the difference between the inside of the lung, alveolar pressure, and the pressure prevailing on the outside of the lung. So, lung pressure minus pleural pressure. And that's the negative one, so our transmural pressure in the lung is a positive value. And positive stands for opening the alveoli. A negative value would mean that alveoli are compressed and their wall moves inward, causing atelectasis. But this is just rehearsal, right? It's not just pressure differences across the lung we are interested in, because the lung or the respiratory system has two cavities that each have their own deformation eigenschappen, properties. Now, the total compliance or elasticity, which is the reverse, the deformability of the respiratory system, compliance is the sum of two different compliances, the lung compliance and the chest wall compliance. And indeed, depending on the type of disease, either one may be the cause of reduced compliance of the respiratory system, which burns down to the same effect. We need higher ventilation pressures to obtain the same lung volume changes, right? But the interest is in finding out which compartment is actually responsible for this abnormal situation, because it has a different impact on how we manage it. So in order to find or to differentiate, we need, first of all, to measure pleural pressure, because that allows us to calculate transpulmonary pressure, alveolar minus pleural pressure, as we said, which is positive in functional residual capacity condition as after a expiration, calm expiration. But then there's also the chest wall transmural pressure, the pressure over gradient over this component here, and that's the difference between pleural pressure and atmospheric pressure. Atmospheric pressure we can then neglect, because that means actually pleural pressure is the transmural gradient for the chest wall. And finally, there is that total respiratory system. That's the difference between the alveolar pressure and the atmosphere, or atmospheric pressure we can neglect and use alveolar pressure for that. And then here you see the relationship between volume and pressure in the lungs. Pressure this time defined as transmural pressure, not just pressure, transmural pressure, and different transmural pressures. Certainly the one over the lung, here in green, and also the one over the chest, which has a different relationship if we let patients inhale to full lung capacity and then allow them to exhale in steps and every time stop and measure the evolution of the pressures. That's like a static volume transmural pressure curve. And then we can actually, these curves, or the steepness of these curves, indicate, I don't see they equalize, they indicate the compliance of the different systems. The chest wall compliance, and it shows if we exhale, expiratory volume functional residual capacity, we see that the lung actually has a negative transmural pressure. That means it wants to expand. Is that already a signal that I have to stop? Whoa. At functional residual capacity, you see that both structures, both transmural pressure gradients, equalize each other out. That's enough signals, but I see them, I still have 4.5 minutes. So that's the information behind this graph. So if we inhale, our lung volume increases, our pleural pressure, because the lung cavity increases, becomes even more negative, and that means our transpulmonary pressure, the transmural gradient across the lungs, which we can only estimate or measure with an intrapleural measurement, pressure measurement, is at its maximum when the cavity is at maximum volume, that is at maximum inspiration. And then you see that the lung pressure, the pleural pressure, it goes less negative again because the lung now, that's a passive phenomenon, collapses and pushes the alveolar pressure a bit upward, and that increases or that induces exhalation. This is a spontaneous breathing where you see the transpulmonary flow and pressure increase during inspiration, and actually mechanical ventilation does exactly the same, only here we increase alveolar pressure to push open the lung, and that is also to create a positive transmural pressure across the lung, and pleural pressure increases instead of decreasing, and also alveolar pressure, of course, that's our trigger, and the result is actually almost similar to what happens during negative ventilation. So some groups consider it of equal efficacy. That's not really a consensus. Right now, there are different mechanisms, and maybe I can illustrate by also describing the driving pressure. That's the difference between the alveolar and the atmosphere. Alveolar and atmosphere, which makes that air moves in or out of the lungs. So in inhalation, we have a negative driving pressure pulling air in. At expiration, normal expiration, the lung resumes its volume and pushes air out. But forced expiration, that's why I show the graph, means that we now, due to active contraction of the muscles, produce a positive pleural pressure that transmits to the alveoli to push air out at very high pressure, and so very high flow. And flow by itself creates a pressure decrease. That pressure decrease can lead to a reversal of the transmural pressure, not in the alveoli, but in the bronchi that are collapsible, because due to pressure decay, the pressure now has become lower than the one in the pleural cavity. And groups, especially Jan's group, is exploring the side effects of positive pressure ventilation, where we have where we build up pleural pressure that during expiration, which is passive, may then collapse airways, because we go from very high pleural pressure towards a near zero alveolar pressure, which may decrease or collapse the diameter of these vessels. And so the solution to that is to prevent this rapid flow due to the active forced expiration or restoration of volume after expiration with mechanical ventilation, to oppose this rapid flow and therefore decrease in pressure over the bronchi or bronchioli that can, with small diameters, that can collapse them and create airway trapping this is actually also the principle behind the application of PEEP. I will work on the nerves of Jan now, because I was going to give some examples of what happens when there is a decrease in chest compliance. That means the red line will now be less steep, that means more pressures for the same change in volume, versus ARDS, where the compliance of the lungs decreased. That is the green line that now moves to the right. That's the transmural pressure or transpulmonary pressure gradient, and the result in both conditions is that alveolar pressure or transmural pressure of the respiratory system, of the entire system, is increased, and therefore compliance is decreased. The lower one will have a far more effect on the afterload of the right ventricle, compress the alveolar more. The upper one is actually less threatening because the transmural gradient over the lung remains the same. So if expansion of the lung requires higher airway pressures, then we can do that without damaging the lung, because it is primarily that increased strain on the lungs, transmural gradient, that will cause the defect or the harm. So measuring esophageal pressures is not a new idea. That has been done in the 60s already, but it's actually entering critical care practice. I just refer to these papers for you to look at the details of it. Intra-abdominal hypertension, for example, is a clear situation where pleural pressure is increased. And you see when intra-abdominal pressure increases gradually on the x-axis, that there is an effect on esophageal as a surrogate for pleural pressure, both during in and expiration. So that means the transmural gradient over the system increases, and if you measure pleural pressures, you are able to distinguish the effect caused by pulmonary, transpulmonary gradient increase, which here is not the case, because the disease is in the chest wall or in the pleura and not in the lungs, while the major effect comes from that lung compliance, from that thoracic wall compliance. The net effect is a respiratory system compliance that decreases higher airway pressure, but not because of lung problems. This is the summary. It's probably on the website.
You go ahead.
I wanted to attribute it to a real pulmonary physiology or a novel star who died a couple of years ago, over hidden still. Thank you very much.